parts to my talk. One is on how you monitor the brain, and the second is going to touch on focal theory of epilepsy and then the network theory of epilepsy, as both these aspects are kind of quite important in the work we do. So in terms of monitoring the brain in epilepsy, we do this for two reasons. One is for decision-making for epilepsy surgery. There are a number of things that we do to try and control seizures. For all of this, we need to understand where the seizure arises from, and then we go in and surgically either remove that part or otherwise put in a brain device to control it or ablate it in some manner. Another reason to monitor the brain is to be able to bring in closed-loop feedback control to control seizures as they occur. So there are a number of modalities used in clinical practice and for research. The ones that are on the left are MRI, PET, SPECT, fMRI, MEG, scalp EEG, intracranial EEG are all in current clinical use. SPECT perhaps not at all centers. The ones on the right are less often seen, but different labs do use them, use wearable devices, near-infrared spectroscopy, subdermal electrodes, brain microdialysis, single-unit activity measurements, and implantable devices. I'm not going to talk about the imaging modalities. This has been presented by others in slides over the last several days, but the first three of these are true imaging. You get static images, and the fMRI and MEG give you short-term time series. While the person is in the magnet, you can get a capture of the brain activity. For us, of most use is the EEG, because here we can do long-term monitoring of the brain over days, weeks, if necessary, and that's when we can capture seizures. Seizures occur randomly, or nearly randomly, and they're spontaneous. There's nothing that tells us when a person's most likely to have a seizure, at least for clinical purposes, to be able to tailor just a short-term study with fMRI or MEG. So scalp EEG, well, first the EEG is a signal in general, microvolt level activity, discovered more than 100 years ago. It has a role in epilepsy, quite a role, central role in terms of allowing us to study and make clinical decisions. Typically, we record it synchronized with video so that we can correlate the person's behavior and motions with the electrical expression. And the basis of the EEG is a net voltage drop caused by a net ionic current over the resistance of extracellular space. This is an anecdotal model that we have. The field, one of the gaps in the field that's been there since the signal was discovered is that we don't have a good model for the EEG, and this is a failure for the field overall. It's a macro measure. It's sensitive to synchrony of the underlying neuronal pool. It's also sensitive to the electrode position and orientation. Scalp EEG, you might all be familiar with it. You have a standard placement scheme. It's called the 10-20. You have electrodes, cup electrodes like this. There's a grass electrode placed at different points. You put a little bit of gel to decrease the impedance, make a good contact with the skin, and you make measurements, and you might capture seizures if you monitor long enough. We are primarily interested in intracranial EEG. There's a tremendous difference between scalp EEG and intracranial EEG. It might be just a few millimeters apart where the contact is, but the intracranial contact is sitting on the generators or within the generators, while the scalp contact is sitting at a distance and subtending a sort of solid angle and capturing the field within that solid angle. This is a study that we did which sort of shows you that if you have intracranial contacts very close to a scalp contact, the ratio of the power that makes it from the intracranial source to the scalp is roughly 15% in the lowest frequencies, and then it drops to roughly 5 to 7% between 8 or 4 hertz to about 30 hertz, and this is probably all noise influence on the scalp EEG. So the intracranial EEG is capturing orders of magnitude more power than you are capturing with the scalp signal, so just going within the generator. You're also looking at signals in a very local manner. You don't have a broad field with the intracranial signal. We often say that it has tunnel vision. It can only see the generators immediately around it. It's also a much broader spectrum. Sure. Sure.
about when you take the EEG. I mean, of course, you have all these peaks and up and down, or whatever. And then you have, for instance, an artifact. I mean, the person moves, the person jumps, or whatever. I mean, these external impulses, are they more or less the same size in microvolts of a seizure, or are much bigger and then you can easily neglect them?
Right. So that's great. On the scalp EEG, you make a good point. You can get artifacts. The artifacts are from electrical generators like muscle, eye, tongue. So like a blink artifact, you can see it go across the scalp. It'll be largest in frontal electrodes, and then it decreases as you go back. It can be much larger than the brain signal. The muscle artifacts will be larger, can be larger as well, depending on which muscles are being activated during chewing. These are pretty large electrical activities generated. The artifacts typically have a certain time frequency structure. So the eye blink is very low frequency, large amplitude, and has a certain spatial distribution. The muscles also are greater, closer to where the muscles are, the main muscles are located, and their sort of spectral content sits in a certain frequency band, which overlaps with the EEG, but it's also distinct. There are parts of the EEG which are separate. But scalp EEG can be contaminated with muscle artifact, eye blinks. The intracranial EEG tends not to be contaminated in the same way. The only contamination that comes into the intracranial EEG typically is a reference electrode. If you have an external reference electrode, then that can be contaminated and contaminate all your signals. So if you pay a little bit of attention to placement of your reference electrode, you can get very clean signals with the intracranial EEG. That's part of the promise of this modality. So Klaus, for example, yesterday had a capture of seizures that was quite long and didn't have noise in it. Otherwise, that person was possibly, at some point going to develop movements, and that does not necessarily contaminate the intracranial signal. But the magnitude can be quite large, and it does impact the scalp signal. So we focus on the intracranial signal, and as you can see from this example up here, it's not just the amplitude, it's a much richer signal in terms of its broadband spectral content, much broader than the scalp signal, and carries a lot more information. So we measure electrical activity directly from cortical surface and or selected subcortical structures. The methods have been in use for more than 50 years. It's a gold standard for localizing the seizure onset area, and it's helped define this concept of an epileptic focus as a discrete area of the brain from which seizures arise and spread. The state-of-the-art instrumentation, it's modular construction with high channel counts, more than 512 channels. It can capture DC to high frequency band. You might be able to save 2 data streams, one captured at 16 kilohertz or higher, one captured at 4 kilohertz. It's capable of both single unit recordings as well as macro contacts. So has low impedance, high impedance amplifiers. It has a decent database, full backend support, security, cybersecurity aspects, and user interfaces that are quite flexible and quite good. The state-of-the-art instrumentation has, all of these aspects. You don't always see every aspect of it. And the research, the noise rejection, the A to D resolutions are about 20 bits or better. Noise rejections, 120 dB common mode rejection ratio. You can collect a lot of data with this. You sample, if you're sampling at 4 kilohertz or 16 kilohertz or 30 kilohertz, you might end up with hundreds of terabytes of data per year with the intracranial electrophysiology plus the video that's being captured. Research-grade equipment from Neuralinks, BlackRock, and other such manufacturers, you can have 1,000 channels of data, and the sampling frequency is much higher, 30 kilohertz higher. The signal part, I want to walk through this because quite often we take it for granted, and we don't understand it fully, and we need to understand this because our signals completely depend on it. There are 8 parts to it. There's the electrode, a preamplifier if you use it, the amplifier, anti-aliasing filter, the A to D conversion, and then 6, 7, 8 is offline, compression, transmission, storage, montages, and filters, and a display. The electrodes we use tend to be of a few kinds. So you have strip electrodes, grid electrodes, or what we call here the depth electrode. These are all typically silastic. They're flexible electrodes. This is a flexible catheter construction made out of silastic or PDMS. It typically has an outer diameter of 1.2 millimeters, or can be less than 2 millimeters typically. It's flexible. You put in a stylet, like you see there, to make it stiff, and you introduce it. And this can also be introduced by robotic sort of measures, so it can be automated and targeted to different structures. The intercontact spacing typically is 10 millimeters center to center. The metal's platinum, or you might have other sort of metals that are used. Typically, previously they used stainless steel, but recently it's mostly platinum or platinum iridium. The construction of these electrodes are essentially two silastic plates with metal contacts in the middle and wires connected to the metal contacts. The construction is quite simple, hasn't changed for a number of years, though there are groups that have started introducing true thin film electrodes now. I showed this image once to a CEO of a company I wanted to collaborate with, and he told me I'd ruined his day. And I went back to the neurosurgeon who had placed this, and he said, I don't know what's his problem. This is a beautiful image. So, your perspective might differ. This is a young woman, 17 years old, lying on her left. This is the right side of the brain that's been exposed. The ear is here. The nose is up there, if you can see my cursor. This is a 5x7 grid electrode. There are depth electrodes being placed here. You see this one? This is a depth electrode being placed into hemispheric space and targeting the medial parts of the frontal lobe. And this is covering a fair amount of the frontal lobe. So these are macro contacts placed, in this case, with a craniotomy, where the skin flap's been opened, the bone has been opened, taken out, and the electrodes have been draped over the cortex. If you do a reconstruction, this is unusual now, but you can see in this case, the surgeon wanted to cover a large amount of the cortex with literally, we place hundreds of contacts. This is a grid that's been cut in some parts here, covering parts of the temporal lobe. And then once that opening's made, you can put in strip electrodes in freehand. So all of these are strip electrodes going into the posterior parts, the occipital lobe, or going to this inferior temporal parts or the frontal parts. You place these electrodes, you close up the skin flap, you send the patient back to the ward, and then you record. You're trying to capture enough seizures to know where the seizure onset area is. More recently, this has changed. The kind of electrodes we use throughout the world, this has changed, and it's changing dramatically. There's more of a use of SEEG electrodes. These are like the depth electrodes I showed, because we now have robots that can place these electrodes in a pretty efficient manner and fairly safely and very targeted. It makes it easier. You don't have to open up the bone and remove this, and put the bone in a bone bank and, close the skin, etc. And the patients tend to recover more quickly, but it's a much lower sampling of the brain then. This image doesn't do it justice, but there are other images you can find online. These are all, depth electrodes that are being placed. So there's less sampling of the cortical gray matter because you're not draping electrodes over the cortex. You're introducing depth electrodes to target different parts of the brain. The promise of this, and this is 30 minutes of continuous recording, so it's just a continuous trace. And you can see a clean recording and with a seizure captured here, just like the recording Klaus showed us, except this is from a single channel as opposed to multiple channels. And this is a person who had an onset in the left posterior temporal area. And you can see the seizure emerge from the background, build up, and then dissipate and die away. So that's the problem. Sorry, let me repeat. Yeah. So this is just a continuous trace. I'm trying to squeeze as much data as possible. Each of these traces is 30 seconds in duration. And so it just continues going on to the next, So just going from the top all the way through. It's just a long trace of EEG, single channel of one of those hundreds of contacts we place in the brain. So just a continuous recording from there showing that you can collect very clean data with this, with intracranial EEG. So things to think about on this first stage of this instrumentation. One, we use different kinds of electrodes. They're all macro contacts, typically in clinical use, typically platinum or stainless steel contacts. We don't measure impedance, so we don't know how well the contacts are in connection with the underlying brain tissue. Because measuring impedance requires you to inject current and measure the return current, and that requires you to inject current into the brain, directly into the brain, and we would prefer not to do it. So it's unusual for a group to measure intracranial EEG impedance. The impedance may change with time since implantation. We think it changes a little bit, but we don't measure it truly. There have been some instances where we've had to measure it. We were doing some device trials, and it was part of the protocol where we had to measure the impedance, and we were surprised. It was fairly stable, very low, a pretty decent impedance, but it's typically never measured, not measured. The possibility exists for difference in impedance in different contacts. This is, by and large, the field agrees that there's probably not that much of a difference between the impedance of different contacts, but that's an assumption on our part. The second, the preamplifier is typically used to stabilize the signals. It may be put in a head bandage or very close to the person. It's used primarily if you're trying to collect single united, from single neurons as opposed to macro contacts, because the signal needs to be stabilized. It's not very commonly used, so I've skipped it. Then comes amplifier. This is just a typical sort of schematic of a standard amplifier. But the key thing is it's got very decent common mode rejection ratio. So the clinical equipment typically can reject common signals up to a 10,000 order of magnitude. So if signals are common between the two channels, like let's say you have some electrical noise that's come into the reference, you can reject it very well. Okay. The next part of this is an anti-aliasing filter. You're on the analog domain. Before you go into the digital domain, you have to digitize the signals, and that requires you to obey the Nyquist theorem. And you all know that you have to sample at least 2 times the highest frequency of your data. So, that's a simple statement that the sampling frequency should be greater than 2 times the highest frequency. But as you can see in the field, our sampling frequency has changed over the last several decades, and I'll show that to you in a minute. So far, we make an assumption that we know the frequency of the analog signal, and that we can sample at high enough a frequency to fully capture it. Sorry, let me go back here. A poor anti-aliasing filter can result in noise entering the instrumentation system in certain situations. For example, there are people who study the EEG in conjunction with fMRI. And the fMRI, the magnet creates a lot of noise, and your anti-aliasing filter may not kill the signal enough so that noise then comes into your signal, and that's possible. We've also seen it with clinical systems where certain lights have sort of a strobing effect, or they have a regular sort of, within it, a square wave pulse, which then generates line noise at either 50 cycles or 60 cycles, depending on the country you're in, and harmonics of that, because that's typically a square wave, so that's odd harmonics, and the odd harmonics then would be, let's say you had 60 cycle in the US at 60, you had harmonics at 180, etc. That can be too large and can come into your signal because the anti-aliasing filter is not strong enough to remove it. So this is the quality of your anti-aliasing filter depends on your manufacturer, and they typically they have to do this in analog. So the number of components they use defines how good that filter is, how many stages it has, and how quickly and completely it attenuates the signal. Just something to keep in mind about the quality of your data. Then comes the A to D conversion, which is a standard, just a schematic of a 8-bit, sort of an encoder. The key thing here is that you are converting the number of levels. So if you wish, the amplitude of your signal, you do a discretization in 2 ways. You're sampling in time, but you're also discretizing in the amplitude depending on your A to D values. So the A to D bit resolution, if you've got an 8-bit A to D, you've got 256 levels, 10 bits, 1024 levels. Current clinical use, you have 22 to 24 bits, so we're at 4 million levels. That's fine. That's enough resolution. But what you have to keep in mind is our brain-computer interface devices or ambulatory devices typically cut back on this, because each bit costs you in power consumption, and they are very conscious of how much battery is used for acquiring these signals. So they might be operating with a 10-bit A to D or a 12-bit A to D, and that's just something to keep in mind. Otherwise, they can also, if you wish, limit the number of physical A to Ds they have and use them, multiplex the signals and cycle through the A to D, reusing it. In other words, your signals are not all sampled simultaneously across all your channels. So things to think about is a quantization error as you go from analog domain to digital domain, because you are discretizing the values depending on number of your A to D bits, and whether you're truly simultaneously sampling across all the channels. Now, as I mentioned, these parts, 6, 7, 8, are offline, and this is typically done in the epilepsy monitoring unit. The signals are out of the patient's room, and this allows us to then go in and flexibly change the filters in post-processing, change the way we display the signals, analyze it in different ways. Some sort of thoughts about what we are doing. If you're sampling at 256 hertz, you might be capturing roughly 10 gigabytes per day if you've got 250 contacts or so. 1024, it's 63 gigabytes per day. 4 kilohertz sampling, it's 250 gigabytes per day. So you're collecting a fair amount of data. The EEG and video data streams are compressed. Typically, the EEG is a sort of lossless compression. The video is lossy compression, just because you use standard off-the-shelf compression methods. The data are transmitted in packets because they're discretized and they go over a standard Ethernet protocol. So you stop being sort of truly real-time from that point on. So that gives you a sense of how we acquire signals. The advances over the last several decades. In the electrodes, we've gone from wire bundles, and I saw this just in Sao Paulo a few days back because I presented at a university, and the neurosurgeon showed me the electrodes he had made a number of years back, and it's beautifully done. And these were twisted wire bundles, which are, you'd remove the sheathing, and you twist them, and you make a bar hole, and you put them through. And because you've twisted different wires, each one is recording at a different contact point. And these are rigid. Okay, that was the earliest electrodes that were made. Then we went to flexible electrodes because we found if you put a rigid electrode in, the brain itself is separate from, the skull is rigid, the brain floats, and you can get micro abrasions because you have a rigid structure within that. So we went to flexible electrodes in, I think this was in the 80s or so. More recently, you can have multiscale electrodes. So one of the images Klaus showed yesterday was a Binky-Fried electrode. At the tail end of it, sort of you have wires sticking out that can record single unit electrodes, activity, in addition to macro activity. So you can do, collect data at 2 different spatial resolutions, if you wish, macro as well as single units. The number of channels, as I've sort of indicated, as initial channels, 8 or 32 channel systems. Currently, you have up to 1,024 channel systems. The sampling frequency has gone from on the order of 100, 200 hertz to 4K to 30K. The A to D resolution has gone from 8-bit to 22 to 24-bit. And the overall system, previously we used to have film-based systems where you'd actually have a camera split screen, one half of the camera pointing to the patient, the other half is pointing to a paper chart recorder and filming the paper chart so that you could synchronize these 2 parts of the information, the electrical activity and the patient's image. But now we have truly digital video and fully digital systems. So that, if you wish, captures the evolution over the last 4 or 5 decades in this instrumentation. Things that I haven't talked about, we stimulate the brain. Go ahead. Yeah. So essentially, you either sample at a lower frequency for traditional EEG analysis or at 30 kilohertz or higher for single unit activity. So single unit activity is not used in clinical decision making, but in order to capture it fully, you need to sample at higher frequencies, 30K or higher. Yeah. Sorry. Any other questions on this? Okay, great. I haven't talked about the cortical stimulation. We map function by stimulating different electrode contacts. in order to see where the language is and other sort of function. I've not talked about how we visualize the electrodes. We take all this data into software that helps us understand where the electrodes actually were placed. I've not talked about the user interface and the database aspects. Things to think about, we have a great common mode rejection ratio, but we still often get line noise, from the mains, either 50 hertz or 60 hertz in our recordings. And it's good to think through as to where this line noise is coming through. Typically, it's from wires that come out of the patient's head and before the first stage of the instrumentation. These are unshielded wires floating in space, and they might move, and you can induce current in them because they're not twisted, they're not shielded. The amplifiers typically do not measure DC, so that's valuable information that we're not capturing. And the frequency, we used to sample at roughly 256 hertz for many years, but more recently it's higher. Yes?
Do you acquire much more information by increasing so much the frequency of the sampling? Because 256, when you go to analyze, it's pretty high already.
Correct.
Yeah.
So traditional clinical analysis, 256 hertz would have been fine, but there has been, in the last decade or more than a decade, there's been interest in high-frequency oscillations in the ripple band and the fast ripple band. In order to capture them, I think you have to sample at least about 2 kilohertz. And that's why, for us, we go at 4 kilohertz, just kind of a little bit oversampled. But if you are interested, because those signals are typically either up to 250 hertz, or there's been some signals described up to 500 hertz or 600 hertz or so. And the rule of thumb typically is that we go 5 times higher the highest frequency. So if it's about 500 hertz, you want to be at least at 2.5 kilohertz. In my clinic, they go to 4 kilohertz. Yeah. So, but again, that's more on the research side, and we're still fully understanding how best to capture HFOs, high-frequency oscillations, and how best to understand their relationship to the seizure onset area and surgical outcome. The video quality over years has improved. We use the video a lot for decision making, and because these compression standards were meant more for like VHS tapes or some, putting information on DVDs as opposed to clinical decision making. Let's say, do you want to know if someone's blinking or not, or facial muscle twitches? It would be difficult to capture that, but over time, this has improved tremendously. So I'm going to skip over these few slides. I might touch on them tomorrow. The second and third parts of my talk, are more on the information that we capture from the intracranial EEG. So the focal theory of epilepsy holds that activity arises from within the seizure focus, a discrete area which is aberrant. It recruits surrounding normal tissue within its appearance, and then that seizure occurs and spreads. It implies that there is a lack of or loss of balance between excitation and inhibition, that excitation sort of overruns the inhibition, and this out-of-control excitation leads to seizure. This has been the main motivating sort of philosophy or understanding of seizures for the last several decades. I would say probably last 5 or 6 decades. It's the mainstay. It influences a lot of the studies that are done. This idea that you study a discrete part of the brain and understand how it's aberrant and how it might recruit normal tissue. So, what we want to do is locate that and either then use resection, disconnection, ablation, or neurostimulation to control the focus. And we use these different electrodes that I mentioned to go in and study and identify where the focus is. So I have represented the time period. This is like a blank canvas, the time in days on the x-axis, and a measure of excitability on the y-axis, okay? This is simple sort of schematic, cartoon almost. On top, I mentioned something that we do when the patient comes into the clinic after having these electrodes placed. We remove the medication. We taper the anti-seizure drugs in order for them to experience seizures. And Christian mentioned this yesterday in his presentation. It's order to, so that we can, this is a very expensive procedure. We want to capture seizures as soon as possible. I've marked seizures with a star on this, and you can see the three parts. There's medication taper. There's a period of vulnerability because you've taken the medications away from the patients, and then you put the patient back on medication. That comes later. So there's an on anti-seizure drugs or on ASDs and off ASDs time period. And there's also, at the start of this, we placed electrodes. We've done surgery to place electrodes. So you have to keep that in mind. That's in confound because the person's also recovering from surgery to place electrodes. So the question over here is that what happens to brain excitability when they go on, you take out the medications, and they go on to have seizures? We inherently, if the focal theory is correct, you should see a ramping up of excitation leading to this out-of-control excitation that leads to seizure. And that's what we wanted to test. This was work done a number of years back. So our measures of excitation, the one that's standard in the field is a measure of the interictal EEG spike, which is a very sharp waveform that's very short in duration, less than 100 milliseconds. It's almost like a triangular wave in the shape. And that's considered a marker of brain excitation. So we said we would measure interictal spikes, and we would check if we see this sort of increase over days. We also measured energy, power. These are very simple classical measures of the signal. Limitations of our study, we're considering all anti-seizure drugs as equivalent, so we're not sort of specifying which class of drug that is. It's really simplifying things. We're also ignoring time since surgery initially. There were studies by John Gottman from MNI, who's done a fair amount of work, but it wasn't a clear statement from we've reviewed his literature. Essentially, he said that a reduction in anti-seizure drugs causes seizures, yes, which results in increased spike rates. So after the seizure, you see an increase in spike rates. So it's almost like after the event has happened, then we see the mark of excitability. So this is one patient studied for 11 days, and what we're doing here is that this person had occipital seizure onset area from the posterior parts of the brain. We had placed 118 channels, electrode contacts. So we're measuring from 118 contacts in the brain. And this is a count of how many spikes we were seeing per hour in those 118 contacts. This is the medication. The person was on one drug, carbamazepine, which was stopped completely by day 3. And the person goes on to have seizures on day 5, day 10 in clusters, and then day 7 and 8 as well. This line here is the midnight of each day. That's where the marker is. What you can see is that rather than going up, when done in this comprehensive manner over multiple days, go ahead. Yeah. No, so when you have this number of spikes, it has to be automated because the experts would refuse to count over 10, 11 days of recording from 100 channels. So what we did is we took a spike detector, a standard spike detector that's commercially available, and we sort of rated it with our team and set the parameters according to the expert annotations. We had roughly 80+% sensitivity and specificity within the tests that we did before we did this analysis. So there are some false detections here, and we've missed detections as well. But given the large numbers that are represented here, I think this is a correct sort of capture of the overall profile. So it's the absolute opposite what we expected. It decreases, then we get seizures, right? Instead of ramping up, it's ramping down. This is the second patient, 113 contacts placed in the parietal. This is a parietal seizure onset area. And you can see the person was on 3 medications. One was not stopped, clonazepam. The other 2, carbamazepine and phenytoin, were stopped after certain points in time. You see this amazing diurnal variation. Typically, spikes are high at night. But then you see this dramatic decrease to a small fraction from 7,000 to less than 1,000 spikes per hour, and then a cluster of seizures emerges. So again, complete reversal of what we had been told to expect. So then I took this same data that I just showed you, and instead of spike counts, I'm just plotting power in different frequency bands. This is power overall, the total power from 0 to 128 hertz. And it shows that same decaying aspect. And then I'm going to break it down into different frequency bands, so delta, theta, alpha, beta, gamma, high. So going from low frequencies to high frequencies. And you can see that decreasing trend is there in this patient in all the frequency bands almost, less so as you go higher in frequency. Okay? But you get a hint of it across pretty broad spectrum. All the traditional EEG analysis sort of bands all capture this decrease.
Excuse me. And what is the distribution of spikes or number of spikes? As you can see in the high frequency, is practically constant forever. So, I mean, what is the signature of a seizure here?
Yeah, so I should make it clear, we're not looking at seizures here. All this analysis has been done by removing data within 6 hours of a seizure. This is all ongoing background signals. So by and large, most of my studies are done on ongoing activity from the background EEG, because seizures are quite complicated. They're periods of high non-stationarity, very complex dynamics, and I wanted to first understand what's going on in the brain if I were to step back and just look at whatever the ongoing activities. So this is not really spikes, these are just traditional spectral measures. So I've taken the data into the Fourier domain and decomposed it in power in different frequency bands, going from low to high frequency. But essentially, what we're seeing is this broad band decrease. Now, as I mentioned, there's a confound in those data because those data were measured after we put electrodes, and the person was recovering from surgery to have those electrodes placed. So we repeated the study in scalp EEG patients. We looked at 130 patients. Of these, 79 of these 130 patients didn't have seizures in the first 3 days. Then they had seizures. This is just a count of seizures here on days 4 through 8. And so we'll focus on the first 3 days, and you can see this, in the scalp is a broad sort of diurnal, strong diurnal sort of change in spike counts. But we also see this decrease sort of trend. So at least we're seeing some aspect of what we're seeing with the intracranial signal. And these are patients that don't have electrodes, surgery to place electrodes. So this was for us a confirmation or some support that what we're seeing intracranially is also reflected in the scalp EEG signal. Now, I don't want to give you the sense that the only pattern we see is one of dramatic decrease in seizures. So these are 6 selected examples. The top 3 all show this amazing decrease and then seizures. The bottom 3 show a different profile. This one has seizures on the decreasing slope. This one has seizures on relative maxima. And same here, you know, not all the maxima, but on some of the maxima, the seizures emerge. So it's not a strict rule that you always see seizures only from the lowest points of that expression of excitability. We do have other patterns. So going back to the question that I posed, yeah?
Those rats, at first when you take off the drug, it seems like you have first a high number of spikes, and after it falls. Do you have an explanation for that?
So I'm not sure that there is an increase or not, but the first few days of monitoring, you have to keep in mind the patient has a surgery on a given day, 1 day recovery in a neuro ICU, and then coming into the monitoring room. And this is early from the time of surgery and recovery from surgery. And we place a fair number of electrode contacts in these brains, so it's possible that the brain is still reacting and settling down. But I'm not sure that this is truly an increase and then a decrease. It's high. The one dynamic I'm kind of sure of is that it's relatively high and then low. That part of the dynamic I'm fairly sure about. But the individual changes that we see, you know, for example, your eyes might have picked up this change or you know, this increase here. Yes, we do see some of these fluctuations. We haven't quantified them fully. Yeah. Okay. So to go back to the question that I posed, very naive question. The focal theory says that there's out of control excitation, ramps up, overcomes inhibition, you get a seizure. Looking at the measures that I have, this is a measure, percent change between an on-drugs period versus an off-drugs period. In both instances, it was 1 hour of data while the person was awake, quietly resting, maybe watching TV, but not talking to anyone, just resting in the morning. And the different measures are spike counts, an energy measure, and a measure of total band power, and then the decomposition of the band power into delta through high frequency bands. And you can see all of them decrease with the exception of the high frequency band. The number of asterisks just indicate how significant the change is. 3 asterisks is a very significant change. A single asterisk here for gamma band, not as significant a decrease. But essentially, we are arguing there's a broad band decrease between the on medications period to the off medications period, seen most strongly in the lowest frequency, in the delta band, but also seen in other frequency bands. It's seen in the spike count and in other measures. So again, a complete reversal of what we assumed based on the understanding from clinical practice, based on decades of experience. So you take these quantitative measures, simple measures, you evaluate it, and we are seeing something quite different. This brings up questions for us. Spikes are considered a marker of excitation. How could you have a decrease in excitation and then seizures emerging from a decrease in excitation? That's absolutely counterintuitive, okay? So something's wrong here. Are spikes truly a measure of excitation? I've started to believe that they're a measure of inhibition or a marker of inhibition. And that would make sense. You take away the drugs, the inhibition drops, you have seizures. But again, that's completely out of sync with the literature and the current belief in the mainstream. So this is the pattern we are seeing. As opposed to the ramp up, we're seeing a ramp down. And then this makes it difficult, okay? So this is a spatially widespread decrease, which includes the seizure onset area, but also includes broad parts of the brain. I did not show you a few contacts. I showed you 100+ contacts placed in different parts of the brain. I didn't even tell you where the contacts are placed. I just wanted to indicate that this was a broad coverage of the brain. This decrease with anti-seizure drug withdrawal is counterintuitive. The observation of seizures at low values is counterintuitive. It requires us to reassess our measures and seizure generation during intracranial EEG monitoring. So we thought about this a bit, and this is our hypothesis, which sort of informs how we are doing our research. We're arguing that seizure generation during intracranial EEG monitoring, there's decrease of cortical tone. So the cortex is always in connection with a central part of the brain called the thalamus. The thalamus is like an important hub, if you wish, within the brain. And we're arguing that the signal from the cortex to the thalamus is decreasing. And the thalamus doesn't understand why the signal is decreasing fully, if I can say that. And this results then in a switch from thalamic activity from tonic, continuous burst mode, which is a known behavior of the thalamus, where it bursts to try to wake cortex up. This is a normal repertoire between the cortex and the thalamus. So the thalamus is not getting enough signal from the cortex. It starts to try to wake cortex up. And then our speculation is that thalamic burst activity results in greater cortical synchrony, which in turn results in seizure. So we published this a number of years back, and this sort of more or less guides our way of looking at, or trying to make sense of this very counterintuitive set of results that we've collected. Now, it's hard for us to test this because we don't routinely measure from the thalamus. We don't measure from the thalamus. We've more recently started measuring from the thalamus, but we don't have enough data yet to sort of make a statement on the accuracy of the statement. So this causes a reassessment, right? So the focal theory was extremely successful in some instances. When we remove the seizure onset, the focus area, we control the person's seizures in some instances. However, it's becoming increasingly difficult for us to find a focus in non-lesional patients. There was also other observations that we had made that, within my group earlier, Dr. Spencer and Susan Spencer published papers saying that in a single patient, we're seeing variable onset within the medial temporal lobe, but also overall, it looked like just one component of the medial temporal lobe was dysfunctional, and they remove it, and the person's seizures were controlled. So the variability and where exactly the seizure onset start does not clearly delineate exactly the part that's sick. It's like it was jumping around, if you wish. There's bitemporal epilepsy where both hippocampi show some degree of dysfunction, but then you have to make a choice. Which one do you remove? You can't remove both hippocampi. There's a well-documented case in the literature, you've probably run into it, where both hippocampi were removed, and which had a dramatic impact on the person's ability to recall things and remember things. So we have to remove one hippocampus, and typically if you take out the sicker hippocampus, you control the person's seizures to some extent. So it's almost as if this is a two-node system. Taking out the more sick node controls the other node. It's like a daughter node, if you wish. Failure of complete, also we are observing failure of complete control of medial temporal lobe epilepsy over time. So all of these things were troubling us, and these are papers that appeared about more than a decade back. There's a paper from the Cleveland Clinic showed that only at 5 years, only 30% of the 70 patients with frontal lobe epilepsy were still controlled after surgery. And in another group, 53% of temporal lobe epilepsy patients at 10 years were controlled. So only a small fraction. After 10 years, only 50% of patients where we were so absolutely certain of the seizure onset area, and you removed it, were controlled. The others started to develop seizures. This is a paper from a group in Australia saying that at roughly a median follow-up 10.3 years, 56% had less than 20% of the preoperative seizure burden, but seizures were completely controlled in only 14%. So removing a discrete part of the brain where we think seizures come from was not giving us long-term seizure control. After half a decade, these patients that we were so confident about are coming back with seizures. Despite the benefits from surgery, in some patients, all the epileptogenic regions are not being identified in a substantial portion of the patients. And that gave rise to the network theory, if you wish. This network theory came out of my postdoc mentor, Susan Spencer, and her paper of 2002. Essentially, Klaus had some of this in his slide yesterday. She considered epilepsy as a disorder of large neural networks as opposed to a focal area. And this is directly from her paper. Consider a network as a functionally and anatomically connected, bilaterally represented set of cortical and subcortical brain structures and regions in which activity in any one part affects activity in all others. So very different from the idea of a focus that's aberrant. Now it's a network that's aberrant, and a large-scale network. Dr. Spencer, identified 3 possible networks: a limbic area, medial temporal, superior parietal, medial frontal, medial occipital, lateral temporal. The strength of this was a clear alternate to the regional or focal theory of epilepsy. It's a clear, it's a paradigm shift, inherently more fitting with our improving understanding of the brain. So over the last 2 decades, there have been so many studies of the brain as a network and so many domains, and this is increasingly how we look at the brain. And there's accumulating evidence from neuroscience, studies in psychiatric disease, studies of cognitive networks, etc., all support sort of a network perspective, if you wish. This has been influential over the past 2 decades, and it brings us, as an engineer, I'm happy, it brings us into the domain of system theory, which is quite powerful, and we have a lot of tools to apply from there. The weakness of Dr. Spencer's paper was there was an unclear definition of the nodes and edges, and a hierarchy of the nodes, if any. It's not clear if are all nodes equal? Is one more critical than another? That was not clear. The nature of the network aberrance, how exactly is the network aberrant, was not clear. The temporal definition of seizure onset and offset, like how does the network go into a seizure and out of a seizure, was not clear. The example networks are intriguing, but other than the limbic network, which is well defined, the other 2 networks were not that clear and are not that common. Okay? We don't see that in many patients. And there's a lack of clear, actionable information in her paper. So don't get me wrong, it was revolutionary work. It's a paradigm shift in our thinking. And she was willing to put it out there as a very clear statement on what she saw based on clinical information, forcing everyone to think differently. But this is, if you wish, the weaknesses of the paper at that time, 2 decades back. So in 2019, with Klaus and Bjorn Shelter, at one of our seizure forecasting meetings, we organized a set of 6 debates. And because there is a lot of work to be done in the network theory to help put it on better ground, on better footing, and we needed to clarify certain things. So there were 6 debates. 3 of these debates were on aspects to do with defining the epilepsy network. is this a normal network that has been hijacked during the process of epilepsy, or is this a new network that's being formed as the person develops epilepsy? What's the best temporal scale? Do we study it for 5 minutes, 1 hour, 2 hours, 6 hours, 24 hours? How do we understand this network? What's the best spatial scale to define the network? And then the second set of debates are more on how to control epilepsy if it arises from a network. And we published this. We say that seizures arise from an aberrant network. A network, at a minimum, should have 2 nodes and 2 edges, one from A to B, one from B to A. So that, if you wish, is our unit, our smallest unit. That's a network. If you look through the literature, and people who work on networks will tell you they're using network measures, they're studying networks, but most likely they will not tell you clear anatomical regions in the brain, which are their nodes, and what are the edges of white matter pathways between one node. The brain has very clear-cut white matter pathways, but those are not defined by them. So the implication when we speak of network aberrance then is we have one or more aberrant nodes, either A is aberrant or B is aberrant, one or more aberrant pathways, either A to B or B to A. We have both aberrant nodes and aberrant pathways, or the network is aberrant as some sort of emergent property emerging from that entire configuration of those particular nodes and pathways. So you could have, nodal pathway, nodal and pathway emergent sort of properties that give this rise to this aberrance. Okay, this is, again, keeping things very simple, but we're just trying to understand, if I were to take this into the brain and look through the literature over the last 2 decades, we don't see elements of this. This is what's missing, this sort of understanding of parts of the anatomy, parts of white matter. What's aberrant here? How exactly is this a network that's failing? If you have this sort of setup where A to B and B to C, B and C are connected, A and B are connected, and during epileptogenesis, the process when epilepsy develops, this network, AB, becomes aberrant. And is it possible that over time that B and C will become aberrant as well based on the aberrance of A and B? We have no idea. That's a speculation. Yeah. Is this something that over time influences other networks, or are they nested networks or attached networks? And in our case, we are so used to, over decades, of treating a node. That's at best what we do. You go into the brain, identify a dysfunctional area. That's our seizure focus. You treat it. You remove it, or you stimulate it. So what we are doing is, intervening at a node, and if it's a nodal and pathway aberrance, you're leaving that pathway in place. That's just something to think about. Our intervention and our monitoring, everything I defined previously, was built for focus theory, the focal theory of epilepsy, trying to identify and then control a focus. But now we're shifting to this domain where it's a network, and we need to think through how do we control, monitor and modulate a network. So, let's say we had this situation and you had epileptogenesis and A and B is dysfunctional, and our methods identified A as a dysfunctional node. We removed it through surgery. We're still leaving this other part in there because it's not sort of manifested itself fully in developed seizures, and maybe 5 years later, that's going to start expressing itself, with seizures. So, I continue my analysis. I'm looking only at interictal activity. That's the ongoing activity between seizures, not looking at seizures. And I just want to put forward something that's, if you wish, a bit anecdotal, speculative. It's a hypothesis at best. So we argue it must be possible to define the network based on ongoing activity, that this network, which is aberrant, it's expressing itself continuously, and we must be able to pick up this aberrant expression by studying long enough, hoping to pick up some of its signatures. So one study that we've done has got 14 subjects, average age, all underwent epilepsy surgery, average age of 33, 6 of them are women. And I broke them into 2 classes, those with excellent outcome at 5 years and those with poor outcome at 5 years. Just remember, excellent outcome, EO, poor outcome, PO, okay? So 8 of 14 had excellent outcome and 6 had poor outcome. And our patients are quite diverse. They're not guaranteed to all have seizure onset in one area with one kind of etiology. This is a heterogeneous set of patients with very bad epilepsy that come to us, and this was an unselected set of patients. So 5 of them had medial temporal onset, which we heard on earlier in the week is a very epileptogenic area of the brain, the temporal lobe. And 9 of them had neocortical, or the rest of the cortex. Okay? On average, each patient had 192 electrode contacts. The electrodes were all put onto a standard common brain. Now, first thing you do, I did was look at coherence. So it's a measure, if you wish, a frequency index measure of correlation, going from low frequency, sorry, in this case, I was looking at a high frequency gamma. This is, the measure goes as 0 to 1. It's a linear measure of similarity. 0 means there's no similarity, and 1 means there's perfect linear correlation between the signals. And this is, I'm measuring relationship between pairs of contacts on the brain. And as you increase the distance, so at short distances, you get high values, and then it dies down. So our relationship measures in the brain in this frequency band tend to die down, actually in all frequency bands, tend to die down kind of, so that by the time you're at 5 centimeters inter-contact distance, it's pretty low values. I took measures, I defined a local measure of connectivity within either like 0 to 5 centimeters. So this is, outer circle represents, if I had a contact here, this is 5 centimeters out. The inner circle is 3 centimeters out, just to give you a sense of how much distance sort of is captured on the brain. And I'm looking at relationship between parts of the brain that are within a local distance. I plotted in this manner. The x-axis is distance to the seizure onset area in centimeters. So 0 means the seizure onset contacts, and 1 means you're 1 centimeter away from the seizure onset contact, going to 10 centimeters away from the seizure onset. So let's say seizure onset's here, I'm stepping away from it. Okay, I've removed all aspects of anatomy other than just Euclidean distance away from the seizure onset area in centimeters. And the y-axis is my measure of connectivity. How much local connectivity do I see? And then I broke in, remember you had roughly half the patients had good outcome and roughly half had poor outcome. So the excellent outcome group, and this is all looking in a certain frequency band, has this sort of profile with respect to distance. And the poor outcome group has a more complicated profile with respect to distance. I marked S as the seizure onset area, P is periseizure, D as distant, periseizure onset being 1 to 4 centimeters away. So this profile is interesting. This is increase, then a decrease, while this one shows more complex sort of pattern. If I look at all the different frequency bands that I'd mentioned earlier, I see that profile in beta, but I also see a hint of it in alpha, gamma, high frequency. All of these measures were made from 1 hour of awake, resting EEG. So the person's not really engaged in one task for 1 hour. So all language networks, motion, etc., is all being washed out. And we're hoping that what's remaining is an expression of the epilepsy. That's our thought. Okay? But we're seeing this profile, if you wish, repeated in the alpha through high frequency bands, but not really in the theta and delta bands. And then I took this a few days later when the person's off medications, and the red is off medications, the blue is on medication. And you can see a attenuation in the off medication, but that profile remains. It's that same profile of increasing as you step away from the seizure onset area and then decreasing. And you see it repeatedly. So even though these are 2 independent measures, well, independent, like days apart, after medication has been tapered, we're seeing the same sort of expression with respect to distance from the seizure onset area. The next thing I did is I took this profile and I rotated it. Now, truly, it's a 4-dimensional structure on a 3-dimensional convoluted brain. But let's, instead of having it in 2D here, let's make it in 3D. So I'm just taking it, and rotating it around the seizure. Because I wanted to better express what its structure is. Its structure is what we call a caldera. Like if you have a volcano, the top blows out, you have a crater remaining. So the connectivity structure, if you wish, is low, far away, and then goes up to a rim, and then decreases slightly at the seizure onset area. Now, as an engineer, this is a nice structure for me, because I can climb a hill with my algorithm, with simple hill climbing algorithms that exist in computer science, and you just, wherever you are, you climb a hill, and you see if you get close to the seizure onset area, without knowing where the seizure onset area is, right? You have no information, you just start doing a hill climb search. So this is an illustration of a patient who has right anterior superior lateral temporal onset of seizures, has electrodes placed all over here. So we're covering a fair amount of cortex with electrodes, and you do that Hill search from each contact, and all of them end up in this region of the brain. So even though I'm starting several centimeters away, there is a connectivity gradient going from several centimeters away to the seizure onset area in this patient. Okay? And my search algorithm sort of goes to that point. So if you were to show it on the brain and then just as the vector from each starting point, the length of the vector shows how far you traveled before you stop, they're all pointing to this part. So that was interesting. So this is, in my mind, a signature left over from the epilepsy process that's showing up in the ongoing interictal background sort of activity. This is a second patient with left superior parietal onset of seizures. The two contacts here are the seizure onset contacts. It doesn't go to the seizure onset contact, but the rim is like 1 centimeter away or a couple centimeters away, so it goes close to it. It goes to proximity of the seizure onset area. It doesn't just go there. There are other areas that are further away that the algorithm also goes to, like in the frontal lobe. But at least where the seizure onset area is and large parts of cortex around it seem to have this gradient, which is interesting. So I showed you a couple examples. This does not predict if these examples are selected. One is a good outcome patient, one's a poor outcome patient. This existence of this gradient is not telling me whether they're going to have good outcome or poor outcome. It's just a way that the seizure onset area and the cortex around it seems to be organized. The other thing I did is, again, a certain simple theme here is that I'm looking at high frequency signals in those alpha through gamma bands separately, and the low frequency and delta separately. These are the two profiles I showed you in gamma and delta. Made a very simple classifier, 14 patients, a single line, and you find that all the poor outcome patients are here. You have gamma coherence on connectivity on the x-axis, delta on the y-axis. All the good outcome here, of course, there's one misclassified for both groups. This is human data. You're never going to get something perfect. So out of 14 patients, based on 1 hour of ongoing activity, I can predict who's going to have good outcome to surgery and who's going to have poor outcome to surgery. That's interesting. Again, not anything that's conclusive because it's only 14 patients, but they have been studied up to 5 years, which unlike most other studies which go to just 1 year or so when they're looking at surgical outcome, at least we made sure we followed them up to 5 years. So I'm good, and this is work done by a fellow who worked with me previously, currently finishing his residency at Boston Children's in pediatric neurology. Here he's looking in the delta band at the envelope, coherence of the envelope of the delta band time series. So you make measurements of delta power over long periods of time, and then you look at the coherence of the envelope of that delta power time series. And as a function of distances between contacts, and you can see that at least here, there is a difference between the on medications and off medication periods. So when there's medications are withdrawn, this sort of connectivity seems to increase. And then you go further, you get closer to the time of the seizure, and this connectivity, long-range connectivity increases, going from pretty low values in the on medications to pretty high values as you come to the pre-seizure period. And, so there is at least a change in this low frequency band as we get closer to seizure. So I want to just, in the few minutes I want to put all these pieces of information together. As I mentioned at the start of this section, this is a bit speculative. This is my, if you wish, a hypothesis I'm generating. On top, I have what I showed you first of this dramatic decrease in this broadband measures of excitability when you go from the on meds to the off meds time period, with the greatest decrease in delta power. At the bottom, I've shown you the work from Rasesh Joshi showing this increase in delta synchrony when you look at this envelope of the delta time power series going from the on meds, off meds to pre-seizure time periods. Here I have that connectivity profile in higher frequencies, in the beta band or the gamma band. And here I have this search algorithm also working in the higher frequencies. So I've got two separate pieces of information here. One in the low frequency, delta, second in the high frequency, and I can build a classifier. I'm treating these then as independent pieces of information in low frequency, high frequency. I know that what's in the low frequency, in the high frequencies has this spatial profile where you have highest values 1 to 4 centimeters from the seizure onset area. Not in the seizure onset area, but just in the peri-seizure onset area, around, the seizure onset area. I don't see that profile in the delta band. So my speculation is that we have this sort of a structure. This is, a network model that I sort of assume is motivating the data, that there is a subcortical structure that is activating the cortex and it's manifesting in low frequency band, primarily delta. And separately, there's a higher frequency sort of coupling that I'm seeing that is cortical-cortical in nature, and that's in alpha through gamma bands. And these are two separate sort of motivations of the signal I'm seeing. So I'm sort of suggesting there are two main components in the epilepsy network, a low-frequency component suggesting possibly thalamocortical and cortico-thalamic aspects of seizure initiation, and a high-frequency activity suggesting cortico-cortical components. Now, the key thing here is that I'm arguing that this is part of seizure initiation circuitry. This entire dynamic of the cortex decreasing in power and excitability, and the thalamus trying to wake it up, is part of seizure initiation. Most people argue, or not most people argue, but many believe that the thalamus might be involved in maintaining the seizure once it has started. I'm trying to argue that this is a dynamic between two large components that's failing, or as part of its normal mode of expression, goes to this extreme event where it goes into seizure. Because the thalamus essentially is not satisfied with cortical input back into it, and so it goes into this other mode. The second part, which is cortical-cortical, my argument, it's almost as if these are the parts that are involved in recruiting tissue and spread. And so that, to a certain extent, comes after that first initiation circuitry. So my argument is we made productive use of background intracranial EEG to gain traction on definition of components of the network, proposed a method for localizing the components, predicting surgical outcome, and proposing a network with two primary components and macro-scale connectivity. So with respect to the debates that Klaus, Bjorn, and I organized in 2019, my personal take on some of the questions that we raised were, how much time do you need to define this network? Do you use, what scale do you study it at? Is this a normal network or an aberrant network that's created during epileptogenesis? My own speculation or take on it is the time scale to define the network is 1 or more hours. You're picking up, if you wish, the signature as the person's engaging in other normal function, but you want the persistent signature of the epilepsy or the aberrance to come through. The spatial scale is on sort of macro recordings. The aberrance is, I think this is nodal aberrance, more so than pathway. I think these are normal cortical-thalamic and thalamocortical connections. I don't think these are unique networks that are set up during epilepsy. And I think the network or aspects of the network are stable over days. So there are points where Klaus and I have a different perspective, but again, this is part of setting up debates, discussing, and to a certain extent, I'm speculating. This is a hypothesis. And this actually is a long-term speculation that's adapted from my PhD thesis. So we argue that seizures arise because input to the thalamus has not been met. The thalamus, some implication, this is a node that needs to be better studied. It has implication for seizure termination, that when seizure represents high amounts of activity, some of this represents feedback to the thalamus. It satisfies the need for the thalamus to know that the cortex is connected to it. And that then could be a termination signal. There's implication for status epilepticus, that this feedback from cortex to thalamus is not being met in the status example, for example, the one that Klaus presented yesterday. It has implication for generalized epilepsy, that it could be a single general model for epilepsy, both focal epilepsy and generalized epilepsy, where the aberrance, in one aspect is the cortical activity is dying down and thalamus is trying to wake it up, and the other part might be the thalamus, which is not responding properly, and cortex is trying to activate thalamus. But this is discussion between the thalamus and the cortex, which is aberrant. And it has implication for how seizures spread. If the thalamocortical activity pathway is active, that could represent how seizures spread through the brain as well. So overall, I'll wrap up now. I started out for understanding how we monitor the brain. in epilepsy, we're very much influenced by decades of the focal theory. And we try to identify, we place electrodes, try to delineate a discrete area of the brain. That's the seizure onto area. And so we can go in and control it, resect it, ablate, or control it using stimulation devices. But if we if we believe in the network theory of epilepsy, we need to change how we place electrodes, where we place electrodes, what information we collect before the decision that, you can only measure if you place electrodes there. If you're not placing electrodes to measure activity in certain nodes, you're not going to pick up the network expression. At best, you're going to have a sort of incomplete picture. So we've got to better understand how the network theory should define, how we can define these networks, how we can study them, and then how can we control them. So it's quite a paradigm shift. Even though it's been 20 years, it's going to take us time to get to the point of completely studying, capturing the expression of the networks, and controlling them. I'll stop there for now. Thanks.
Hello, thank you very much for the very nice talk. My question is regarding the gradients you observed for epileptic focuses. The idea of gradients in the cortex have been discussed a lot lately. Have you checked how these gradients interact with naturally occurring gradients, if they are disruptive or additive or anything like that?
Yeah, it's a great question. Again, is this a normal network? Is it an abnormal network? If it's a normal network, what does the epilepsy process do to hijack it or to use it and change it? Essentially, I'm arguing that certain components are being strengthened and are rising above sort of noise level into this gradient. And it's sort of reorganized around the seizure onset area. Now, one example that I showed you was in the temporal lobe. And there are lots of networks that we know about in the attention, memory, language that fall into the temporal lobe. So this implies that we are going to have to better understand those networks and understand how epileptogenesis is modifying those networks. It's too early for us to know. We've got the work we're doing on the brain atlas we're creating was in part to better understand normal brain networks. What are the spatial distribution? What are the normal brain networks? Where do they exist? And then what's the overlap with our epilepsy networks? Because then you could take one of those patients and put them through a battery of neuropsych evaluations to understand if this is a normal alleviation of that function. Is it functional, that alleviation? That increase in connectivity that I'm seeing. Is it adding to that person's function, or is it sort of taking away from the person's function? We don't know. We're at too early a stage. Yeah.
Any other questions?
Those examples you showed of taking the medication out and having a decrease in the number of interictus spikes, you mentioned that the spikes could be serving an inhibitory function. Is that something we can try to replicate or achieve with some sort of simulation as well?
There could be a few ways for us to go in and study that. I have colleagues who do brain microdialysis to understand neurotransmitters in that area. And if you can better understand, for example, you can go in and study glutamate levels and GABA levels when you have high spike rates and low spike rates. And do you see a reflection of this in those neurotransmitters? Now, those are just two transmitters. There are many neurotransmitters. It might not be that simple that glutamate's elevated or GABA's decreased, and that's why you see a great picture of spikes correlated with a neurotransmitter. But that could be one way of doing it. There are other ways of doing it, even if you look at, you take the spike, it has a very nice, discrete, sharp definition. So you know the exact time of its peak, and you can use that to sort of average and get a, and people have done this, where they look at, think of the spike almost as if it's stimulating your brain and you're getting an evoked potential after that, and you average enough of these to understand what's being activated after the spike, to see if there's any aspect of that that could tell you whether this is broad or narrow, or whether it could be excitatory, you're seeing more frequencies or not. Those sort of areas have been studied quite thoroughly, and I haven't seen anything come out of it that's conclusive, telling us that truly this is excitatory or this is inhibitory. In most of these things, I prefer, if I can do it, is to bring in another modality, because electrophysiology is great, but it's a single dimension into the brain. And if you can bring in neurochemistry and another dimension or multiple dimensions with different neurotransmitters, then we can get a deeper mechanistic understanding as to what might be happening. But so far, we don't have that. I have a paper which I've been sitting on, I'm very slow at publishing, which we'll send out, that shows essentially that the correlation between measures of neurotransmitters and spikes, we don't see that strong a correlation between them. That, we would expect sort of excitatory neurotransmitters to be directly related to spike counts, but we don't see it.
Thank you very much.
Any other questions?
Thank you for the talk. I have two questions, much more on out of curiosity, much more on brain.
Could you speak up a bit?
Sorry. Okay. Oh, got it. So I have two questions on brain monitoring. So the first one is if you could talk a little bit more on how to monitor chemical signals, because until now we've been talking much more on electrical signals, and maybe that's an important part of the puzzle. And the other one is if you could talk more about how do you, how can I say it, how to monitor subcortical parts of the brain and other parts that are not on the surface level, such as the hippocampus.
Yeah, sure. So one of the labs that I co-direct, we make sensors, and we're very interested in neurochemistry. Traditionally, we have a very labor-intensive process of measuring neurochemistry, which is brain microdialysis, where you put in a catheter, which has got a semi-permeable membrane at the tip. So, analytes diffuse into the, and you're pumping ACSF through it, and there's a semi-permeable membrane. So you have certain analytes that diffuse into the microdialysate. You take it out, you collect it in a sample collector, you take it through a mass spec machine, and look at the composition. That's a very labor-intensive, time-consuming process. We've done that. We do it regularly. We do that in animal models, and we were one of the few centers in the world, maybe the only center, that did it routinely in epilepsy patients as well, for a duration of time, roughly about 10 years, I think. That's very difficult to do, okay? And it takes a lot of effort. And it's not real time. We would love to have real-time neurochemistry. So the sensors we're developing, they're both electrochemical in nature, where you build certain electrodes, you functionalize them with enzymes or aptamers, et cetera, and you functionalize them enough so that they, the analyte of interest binds to them, creates a signal, and you capture that signal. Or you have optical measures that can be, sensors that can be built, and there are other groups that are doing that, and we are also starting to do that, where you are using light spectroscopy to understand the chemical constituents. While electrophysiology has developed marvelously over the last several decades, this alternate sort of measure of neurochemistry has not developed at that same pace. We don't have the miniaturization, we don't have sort of easy modular systems that we can use in the lab without expertise. These sensing techniques take a lot of work to manage. And for example, if you're doing the brain microdialysis, the membranes get clogged up after a certain amount of time. The dialysate, the analytes you're sort of measuring go down over time. So it takes a fair amount of work. But the value is tremendous. And there's a lot of interest. And there are other groups that are doing similar work, if you wish. But this needs to be developed much, much more. The second question you had is sort of monitoring not just the neocortex, but subcortical structures. So the way we do it is using these depth electrodes. that are the cylindrical construction, and I entered to target sort of a structure. You mentioned the hippocampus. So the hippocampus typically go in orthogonally. From here, you could put 2 or 3 electrodes that could capture activity in a few parts of the hippocampus, like the head, the tail, the pes, etc. Or there used to be another method of doing it where you went in from the posterior and you went along the whole long axis of the hippocampus with possibly a contact in the amygdala as well. But that's the best way we have of sort of targeting subcortical structures. But again, keep in mind, these are narrow, catheter-like constructions with the electrode is a ring on the outside, quite large. It could be 4 millimeters or so in length, the exposed part that's in touch with the tissue. So you're getting very macro signals, and sometimes you need to really understand if you've gone into the hippocampus exactly where you are, because there's distinct circuitry at different parts. So it's not as well done as you might do it in an animal study, where you could much better target subfields, of interest for the hippocampus. I don't know if I answered your question. Okay, thank you.
Talking about microarrays, have you tried using more like refined sensing for localization, or to get an insight of microdynamics, like using Utah arrays to get single neuron potentials?
Yeah, many centers have been doing that. So Klaus's center, one of our colleagues does that routinely. At my center, there's a group that's doing that, led by our current neurosurgeon, Dr. Damisa. There is a lot of interest in that, where you capture the single unit activity. But if you saw the slide that Klaus presented yesterday, there is almost a disconnection between the unit activity and the macro signal, the EEG signal. All our clinical decision making is based on the macro signal. The unit activity becomes more difficult. I mean, which neurons, where do you place this? How many neurons can you capture, and for how long? The Utah electrode array is great, but it was designed in the last century, essentially, and we haven't had the next generation of that ready for human use, if you wish, or more extended human use. It also has a limited time that you get good data. The number of, let's say you put in, it's got 96 contacts. It's essentially a bed of nails on a few millimeters by few millimeters size that you push into the brain. And if you're lucky, you don't move those contacts. You just push the whole structure in. And those contacts then are sitting, some of them are sitting close to neurons, so you can start to pick up neural activity, single units. And if you're lucky, out of 96 contacts, you might have 40 contacts sitting next to neurons at the start. But after a week, 2 weeks, a month, you'll start losing them. And so there is a loss of how many neurons you're picking up. But still, it's extremely valuable. It's extremely nice to be able to go down to the single unit level. That is truly, a level at which we can build a lot of intuition and understanding. If you understand which class of neurons they are, how they're firing, what else is firing in conjunction with it. But that's why those high channel count systems I mentioned, they're going up to 1,000 channels, so that you can put in those electrodes in conjunction with our clinical electrodes. And you have both low impedance, high impedance amplifiers, so you can collect both kinds of information. You can sample at 4 kilohertz and 30 kilohertz and things of that nature. Yeah. So this will take time. It's like almost like you've gone in and opened the hood of the car and you're looking at it. You don't have a manual. You don't know what you're looking at. It's complicated. Of course, we knew it was going to be complicated, but it's fascinating. Those signals are fascinating. There's been some work that's been done, and you might want to look up groups like Kathy Chavon from NYU, from Columbia, and her work, where she's looked at Utah electrode arrays and seizure recordings, and there are descriptions like, not just from her, from others as well who are active in this area, of micro seizures, almost like at the micro wire recording level, you get tiny seizures that don't coalesce into larger events. Like the macro contact sitting next to it doesn't see it, but that contact sees this tiny seizures, which we don't know how to understand. It's a phenomenon like that. But definitely, it's like we're looking under the hood, and it's like fascinating, but we're still waiting for someone to give us insight as to how to proceed.
Okay, so let's thank Professor
Great.
Hitten Zaveri once again. Thank you.
All right. Thanks. Sorry, I should have mentioned one thing. You can find, so I mentioned the Brain Atlas when I spoke on Saturday. If you do a search for, that's what we call our lab, Yale YNN, you should be able to find the Brain Atlas. And you can go in there and explore different kinds of data that we collect. We made this freely available, or at least my students have. If you go in and explore the multimodal data, or the brain parcels, you can start to find things of function. Your question was, how does normal function overlap with epilepsy networks? That's part of the functional determinations we are doing there. You can go in and look at which parcels of the brain are involved with language or theory of mind, a number of keywords. And then where we're going next is trying to understand how that overlaps with epilepsy. Okay, great. Thanks.
Okay, thank you. So we have a coffee break now. We'll come back at 11:30.